Okay, hello. Dr. Norwood here with the wonderful
Dr. Mowrer.
who I promised you guys I would interview. Dr. Mowrer and I have known each other, I don't know how long now,
5 years?
13,
Yeah.
so 6-ish years.
Mm-hmm.
Yep, and she still likes me and has agreed to do this. So very, very excited to do this interview today. Mostly I'm not going to be looking at the camera as I am now because that's somewhat awkward when you're sitting with someone in the room to look at the camera and not them. So I will be facing Dr. Mowrer. I have the questions generated from you guys. So we're going to kind of go through Dr. Mowrer's background and education and how she decided as an undergrad psych major, like many of you are, to take her next steps in her education all the way up to her current position, and then we'll get into the nitty-gritty of assessment and why you love it so much.
Yes.
All right. So yeah, just starting there, if you could begin from when you were an undergrad in psychology and kind of how you figured out, I know one of the specific questions was, as an undergraduate, how you even figured out you wanted to go the clinical route.
Mm-hmm.
And we'll go from there.
Yeah. So yes, I got my undergraduate degree in psychology. I actually started as a psychology major, finished as a psychology major. My dad was actually a psychology professor, but he did experimental psychology, so he did a lot of research on learning and behavior. And so when I went to in undergrad, I wasn't quite sure whether I wanted to go research route, clinical route. And it just so happened I landed a research assistant job while I was in undergrad. And that position was for a research project that was looking at alcohol and risky sexual decisions.
Mm-hmm.
And I actually think this was the point where I started figuring out what I wanted to do after undergrad. So part of my honors thesis was to do some kind of I looked at nonverbal and verbal behaviors and risky sexual decisions. And it got me really interested in problematic sexual behavior and then actually sexual offending, which then led me towards forensic psychology, which is the intersection of law and psychology. So I started looking at opportunities there. And again, I wasn't quite sure, did I want to primarily do research? Did I primarily want to do clinical work? And still, until I started looking into the programs, trying to figure out what I wanted. I applied to both doctorate and master's level. I got into...
So right out of undergrad, you were applying to both doctoral programs and master's programs. Yes. And were they in forensics or clinical or both?
Both. So the master's program I applied to was specifically forensic psych, and then the doctorate programs were clinical psychology, both PsyDs and PhDs, and all of the programs I looked at actually had some kind of forensic specialty as well. So, and I got into a PsyD program and a master's program. And I think this is where the decision came of what I wanted to do. I knew I liked research, but I wasn't sure if I liked clinical work. So I was a bit nervous to go into a PsyD program where there was, 5, potentially 6 years of me doing something, and what if I hated clinical work? And so I thought to myself, well, I could do a master's program, which was a heavily clinical program, for 2 years, and if I hate it, I can kind of get through 2 years and move on and do more research. If I love it, then I can decide whether or not to just practice as a master's level clinician or move forward. So that's kind of what led me to get my master's in forensic psychology. And there I found out that I loved clinical work. So it was, like I said, a very clinically heavy program. And
what kinds of things were you doing? So when you say clinically heavy, there might be some cats making an appearance here. We have a curious cat.
So within the first month of you starting that program, you were already matched to an outplacement doing therapy.
Oh, wow.
So it was a very quick...
Right away.
Yes. Which was a bit intimidating. But
was it a forensic setting where you were doing therapy?
Yep. So my first clinical experience ever was in an outpatient sex offender treatment facility. And so within the first 3 months, I was seeing a caseload for therapy of individuals who had committed sex crimes. And hello, cat.
It's okay.
Who had committed sex crimes, been convicted of it, and then as part of their probation or parole were required to do treatment related to their sexual offenses. So what they called sex offender specific treatment.
Right.
So that was my first year, and then I got hired on actually for my second year as a contractor therapist. And that's actually when I first worked with female sexual offenders, which when we get to my doctorate program was actually my dissertation.
Interest,
so,
yeah.
Yes.
So, and was this individual therapy primarily?
Yes.
Okay.
And group.
And group.
Yes. So I had and then I would, we did sex offender risk assessments there. Because I was a master's level student, I couldn't do those independently. So I would do parts of those, but the majority of my work was individual and group therapy.
Got it. Okay, so I want to kind of move on from there. So you finish your master's, then you end up, that was a decision point, right? Because you had said before that maybe you would, you know, that would be the launching point for if you were going to focus on research, or if you really loved clinical, you might go the doctoral route, which, spoiler, you know, that is what you did, right?
And I think this was a huge point for me because in the 2 years of me doing my master's, I missed some of the research. And so I'm one of those individuals that likes both. And so I was really trying to find a program where I could have a nice balance of doing clinical work and research. And I knew during my second year of my master's, we actually did get trained on some assessments, and I fell in love with it. And I knew that if I really wanted to do forensic assessment, but also psychological assessment, that you'd need a doctorate. And so that's really,
a real, you know, students often ask questions about making that decision between a master's and a doctoral degree. And I think a lot of times we focus on research. Are you interested in research? And then we lean more the doctoral route. But you make a very good point that for psychological assessment, and I had said this to my students, you know, this past week, that this is, you know, psychologists sort of own, right, psychological assessment. That was born out of, you know, our research and continues to develop and evolve. But I was saying I was ordering some of the tools that I need for my clinical research, and you have to jump through a lot of hoops to show that you are qualified and competent in the use of these tools, and that includes having a doctoral degree, and having a license, and having all of the training. So you falling in love with assessment was another kind of important point, important reason for you to go the doctoral route.
And knowing that I wanted to do forensic assessment, so forensic psychology is so broad. So for a master's, a lot of people can do treatment and forensic placements, but to actually do the assessment, so things like competency to stand trial, criminal responsibility evaluations, to testify, you need to have a doctorate. So those things just started lining up. There were multiple kind of points where it seemed very clear to me that to do what I wanted to do, I needed a doctoral degree.
It's also sort of nice for you to share, probably for my students, that, you know, you didn't know for sure when you were done undergrad, right?
No.
And you didn't know immediately in your master's program, but through these experiences that helped you clarify what you wanted to do. And so we don't have to have it all figured out, you know, by sophomore year. In fact, that's unrealistic. And most of us, we can talk about how this is or isn't true for you. And I know I've had my share of experiences, like even what I planned to do when I entered my doctoral program is very different from where I am now, and I like where I am now. But I couldn't have known that.
And I agree with you 100%. If even at the point of my internship, which we haven't gotten there as far as timeline goes, you would have told me this is what I'd be doing, I would laugh in your face. So but I love what I'm doing. I'm happy where I'm at. So you don't know.
You don't know until
you know.
until you know, until you get more information, right?
Yeah.
So you go the doctoral route, and I know one of the questions my students had was about, your decision to pursue a PsyD versus a PhD. So you had said before, when you first applied, you applied to PsyD and PhD programs. So the second, round after your master's, did you do the same thing?
Yes.
Okay.
And I think the important part for me, and something that I think took a little while for me to figure out, was that it wasn't so much about the degree, but the program itself. And so, as I mentioned, I wanted a balance of both the clinical work and the research. And so I was looking at programs that had that balance, where I was going to have that opportunity to do both of them. Some PhD programs had that opportunity. Some PsyD programs had that opportunity. Other PhD programs were very heavily research, and some PsyD programs were very heavily clinical. And so it wasn't so much which one I wanted, but which program was the best fit for me.
Right, which program was offering what you wanted.
Exactly.
So would that be, your advice to students, right, to look more on the program level as opposed to just being pigeonholed based on the degree?
Absolutely, and I think now there's a lot of overlap between PsyDs and PhDs, more so than there was a few decades ago. And so looking at the program, I think, is so important to see, one, what kind of clinical opportunities they have for you, what kind of research interests the professors have, those kinds of things. It's much more about that, I think, than whether you have a PhD or PsyD.
Yeah, I agree. And, basically every setting that I've worked in, I know the same is true for you. There's always been a mix of us who have a PsyD or a PhD in clinical psychology doing much the same work.
Right.
There's not, like, once on the departmental level, where we've worked together, it's not like, oh, I'm going to have these responsibilities because I have the PhD and you're going to have these. That's just not how it works at all. It's really based on our training and interests and experience.
And I know there are plenty of professors that may have PhDs or PsyDs as well, both doing active research. So it works on both sides.
Absolutely.
Yeah.
The other point that's probably worth mentioning for students is the PsyD is really relevant if you're interested in clinical psychology, right? So if you're interested in cognitive psychology or developmental or neuroscience, social, then you're going to be looking at a PhD.
Yeah.
So this is really relevant to the clinical folks if you want to go into direct human services in some way.
Good point.
I sometimes forget to say that because that's what I do. Okay, so you get into your program then. It was Oregon?
Yes.
All right.
Yes.
I forget the name of the program.
It's
but
Pacific University.
Okay.
Yeah, so that was in Oregon. I actually used school as a method to travel.
Yeah.
So,
Oh, Dr. Mowrer is from Texas. It's probably worth mentioning.
Yeah.
Texas. Undergrad in Texas?
Yes, University of Texas at San Antonio.
Master's was in Denver.
Yep, in Denver, Colorado. University of Denver.
This is very smart, by the way, using your education to see the country.
And then I moved to Oregon, so Pacific University. That's in the Portland, Oregon metro area. They only had the PsyD program when I was there. They now have a PsyD and PhD program.
Oh, so you could apply to one or the other.
Exactly.
Interesting.
And so that's where I ended up. And I chose that program for a few different reasons. One, they chose me, so I got accepted into the program. But what I really liked about it is that they did require a dissertation. Research was considered as important as the clinical piece.
Okay, so we'll kind of speed through there. Grad school is not a short thing. A study program is not a short thing, but just to kind of get us more up to speed. So you do your, you complete your program, and then the last year of a clinical psych doctoral program, whether it's a PsyD or a PhD, is your internship.
Correct.
Right? Which I can explain more about this in person to any students who want to know more. But essentially, you're working full time in a clinical setting. you apply, and to maximize the likelihood that you get an internship, right, we apply all
All over
over.
the place. Yep.
And there's this, strange computer algorithm system that matches you. It's all very kind of anxiety provoking. Probably, yes, I can imagine. I've told them a little bit about some of our differences in organization and planning. So for you, probably even more to
Yeah.
have to release that much control on what happens with your life, right? So I imagine you applied all over.
I did. I had, as you can tell when we just talked, I worked my way kind of up this West Coast
Yeah.
with school. I did apply all over, but I was really interested in going to the East Coast. It was somewhere I hadn't really lived before. I have family over here, so that was something interesting
So it was
to me.
partly strategic.
Yes.
And so you ended up at Springfield
Yes.
Hospital Center. That's where we met. I was a postdoctoral fellow in the forensics department at Springfield when you were an intern.
Yes.
A most wonderful intern. So I guess, maybe start us there and kind of catching us up to now. If you give me the Cliff's Notes version.
Sure. So I did my year-long internship at Springfield Hospital Center. Part of that was in the forensics department where I met Hugh. I was fortunate enough then to take your place as the forensic postdoc after my internship. And so that's when we did competency stand trial evaluations, criminal responsibility evaluations. It's a year-long program. And then after that, I got licensed during that time, which is a whole nother stressful ordeal that you don't have to worry about.
Yes, yeah. ways off.
Yes. And I got hired actually in the psychology department.
Right, at Springfield.
At
so
Springfield
you stayed,
Hospital.
right. So
for
in
a short period of
forensics,
time,
we're not providing treatment. We're evaluating and answering questions for the court, answering questions about whether or not, a defendant is able to stand trial or should be held criminally responsible based on, mental illness at the time of the crime. So you then took on a treatment position.
Yes, where I was part-time on a unit doing psychological services, so individual therapy, group therapy, kind of being part of a treatment team, so consulting with a psychology expertise on a team with a lot of other professionals, psychiatrists, nursing, social work, occupational therapists, things like that. The other part was that I was the director of assessment, so really supervising assessments. For more complex assessments, I was completing them myself, just organizing the assessment referrals, things like that. And for multiple reasons, I decided to then leave Springfield for a year, and I actually worked at another place that you and I worked together.
We've had some similar trajectories.
Working with rehab facilities, nursing homes, doing both treatment, so therapy, as well as doing neurocognitive assessments. So assessing whether individuals have dementia, what we now call neurocognitive disorders, and whether or not they could make medical decisions.
Those are some of my most favorite
Yes.
Evaluations there. Yeah, medical decision-making capacity. Because, and I think you had said the same thing, but I found it strangely similar to forensic assessment at least in the process.
Absolutely.
And in remaining objective, and in also providing education and information to individuals who were requesting the evaluations, right? About how someone can be doing very well in, say, one area, right? And have real strengths and really be struggling in another that might not be as clear. Or a person may appear to be struggling overtly, but actually be quite more capable. Yeah.
And I think I really honed in a lot of my consultative skills during this piece, whereas at Springfield Hospital Center, you're working with a team of psychologists, you're working with a team of other professionals. When you're doing the work that we were doing there, I may have been the only mental health professional, and so being able to educate family members, people who are working with them on a more medical basis, so helping them understand kind of what's going on, providing some ideas to help when there were behavioral issues going on and things like that.
That's a very, very good point.
Talking about how people are allowed to make decisions that are different from the decisions that we would make, and that doesn't make them incompetent to make those decisions. And so walking through that, I think it really allowed me to grow as a professional. So though I missed working with my inpatient population, I think it was really beneficial for me to kind of step out, do something a little different, hone in some different skills as well.
Yeah, it's a conversation for another time, but
Yes.
that organization had its own issues.
Yes.
But I think you and I both walked away with a very similar kind of read of that experience as being just hugely beneficial to shaping who we are as clinicians. And I think also another thing we talked about, like really, we both take like a biopsychosocial approach to understanding people, but
Right.
understanding the bio and medical underpinnings, especially in an older adult population, right? Like we learned very quickly when there's like a sudden onset of psychotic type symptoms. Oh, have you done a UTI panel? You know, like, and things that I don't think I could have learned so quickly anywhere else.
Exactly.
So it was very, very neat to get that experience for sure.
And when the opportunity came to go back to Springfield, and that's a whole long story, I won't go into the nitty-gritty details.
But yes, but you end up going back,
Yes,
right?
actually not in the psychology department, but in the trauma and addictions department. So they were kind of doing some reorganization, and I was offered a position in that department. But I think some of the information and things that I learned from that program I could bring back to Springfield and help conceptualize some of our patients there who have more medical ailments.
Yeah, that's a really good point.
Mm-hmm.
So let's come to the current place then,
Yes.
which is you end up back at Springfield.
Yes, I am back at Springfield. I wear many a different hats.
And you're in the addiction, co-occurring disorders, and trauma recovery services
Yes.
department, right? The
Awesome.
other day I tried to say, I'm like, wait, it's so many words. Actors. Yeah.
And also, if you want to shorten, if you don't want to say actors, you can say trauma and addiction. So we kind of use all of that a little interchangeably. But yeah, so I wear a lot of hats in this department. I do a lot of consultative services for a unit just to help them understand how trauma and substance use disorders can also be impacting our patients. I do assessments for trauma-specific disorders, for substance use disorders, and run groups related to those as well. So that's kind of one hat I wear. I also coordinate an externship program, so for students, doctoral students coming in. And then I also do a lot of training, both for students and the hospital. And I think the last thing I do is I do our violence risk assessments and sexual violence risk assessments for the hospital.
There's probably more. You do a
Oh,
lot.
I do a lot. Those are like the big hats.
Okay, and so we're gonna talk today a lot about the assessment piece and being the assessment guru and supervising students and kind of that whole process. But one of the questions I got from students was that I don't want to forget. So one, with all of those hats that you wear and all that you do, what is your favorite part of your current position at the hospital?
So one part of my one piece of that is the variety of experience. So
One of
being
your favorite
able
parts
to
is that there's lots of parts.
Yes. If I had to choose which part I enjoyed most, it's probably supervising. Specifically, supervising assessment is one of my favorite pieces.
So supervising doctoral interns or externs,
Correct.
right, who are themselves actually doing the psychological assessment. I realized for my student, this might be I didn't know anything about supervision when I was a student. So now you're in a position, because you're a licensed psychologist, where you're not always the one doing the assessment, but you're guiding the process and helping them learn how to make these decisions and interpret the information and use their consultative skills and all of that.
Yes, and I think it, just like when you have to teach someone something about anything, you have to really know your stuff, because now you're having to teach it, help them understand those things. So it really just helps me be a better assessor as well.
Right.
To be able to teach at different levels
It's one thing to be able to do it yourself, but then to tell someone how is very different.
Yeah.
So awesome. And with respect to working in the inpatient hospital, because you had said, you know, you were excited to get back there and you love your inpatient population, so do I. But one of the questions was, well, do you like working in an inpatient setting? Which is
yes,
a definite yes.
That's the answer.
And you can expand maybe later or on why, but then the other part of that question was if you feel safe or if safety is ever a concern for you.
Well, I think safety is always something you have to keep in mind. If I say 99% of the time I feel safe, right? So there are always moments when you're working in a facility with individuals who have a history of dangerousness, that there may be times that that are a little bit more anxiety provoking. But for the most part, I feel safe. There's a lot of safeguards that we put into play, and it's something that you always just have to consider when you're going into a room with someone, or whether or not to go into the room with someone. So these are individuals who are most underserved, most stigmatized, and understanding, kind of having that empathy and understanding why they may behave or think the way they do. And putting yourself in their shoes can also help. But with regards just to safety, most of the time, yes, I feel safe.
Yeah, and in that setting, we do a lot with how to prevent the escalation.
Exactly.
Right? And so much of these situations that could become, you know, violent can be avoided based on how we handle them and how we respond.
And I think psychologists play such a huge role in that, and helping people understand how to de-escalate a situation. Even when it looks like there may be kind of what we call a behavioral code, where someone may act out violently. There are so many things that we can put into play to help navigate that situation, and psychologists play a key role in that.
Agree. So we already answered, well, one of the questions was, what other settings have you worked in? And I know you talked us through your different roles at Springfield, and then working with older adults in rehab and skilled nursing. I imagine, and in the master's level in the sex offender treatment clinic, are there other settings that you encountered, like during your doctoral work?
I worked at a Federal Bureau of Prisons in my master's program. I also did community mental health as part of the doctorate program. So I did a lot of neuropsychological assessment there, as well as individual and group therapy.
Awesome. So you've been in other settings, so you can compare and really say you do love your inpatient.
Yes. I actually didn't think I would like inpatient. I thought I was going to work in a prison.
I think that's true for a lot of people, whether not necessarily that comparison, right? I think actually you are somewhat unusual in a good way, but so am I, that we're debating inpatient with serious mental illness and criminally involved, or just pure criminally involved.
Yeah.
Also many mental illness concerns in prisons, but I don't know what you've experienced with your cohort and peers, but I've also, a lot of my colleagues, like in grad school, they were just like, cool, you can have them. I want to work in the community mental health clinic. But hey, we need all of us, right? We need all different kinds of psychologists to do this work. So I want to move into assessment. I'm trying to keep an eye on time because we're good.
Okay.
So that's really what we're focusing on this week with my students. And although I think spending all that time on your path is really just as important, because this is a decision-making time for students. So psychological assessment, if you could give me just like your quick kind of synopsis or overview of like what that means to you and what role assessment plays in the treatment process versus therapy, that might be helpful.
Sure. So, I mean, I think there's a lot of different ways that people can discuss psychological assessment. What I think about is when there's a particular question. So what is this person's diagnoses? What's this person's cognitive functioning? How is this person thinking? What's going on with this person is sometimes these questions that come up in teams. And luckily, psychology has expertise and have developed multiple different tests and measures to help clarify some of this. We have measures that talk about every kind of disorder, whether it's more emotional personality functioning all the way to neuropsychological functioning and everywhere in between. So being able to really help answer some questions about the etiology of disorders, how someone's functioning currently, how this is impacting the way that they're behaving or managing or navigating their world, and ultimately some recommendations on how we can intervene or treat them.
Mm-hmm. Yeah, that was really good.
Thanks.
I mean, you should know. But I've tried to, and hopefully it'll become clear through this interview, I tried to explain to my students just kind of how incredible assessment can be and how integral it is, and how both you and I, and we are not alone, many psychologists have the experience of working with psychiatrists who rely on psychologists to do these assessments, because
Absolutely.
a thoughtful psychiatrist wants to know that they are treating the right thing
Right.
in the right way, so they might want to clarify the extent to which these symptoms are present, or if there's something that they're missing, or even knowing how to communicate information, like how does this person best understand material that I'm going to present to them.
Exactly.
Is there a cognitive concern? Now we'll get into some of these questions about how difficult some of these can be to answer,
Yeah.
or times when it might not be the best for a referral. I think I gave my students the example of someone who has active psychotic symptoms, and there's a question about cognitive capacity. That could be very difficult to tease apart, and you can expand on that. I know my students, one of the big questions is like, is there a typical process, for how assessment goes? Or like a typical formula you use that it might be like that guides it. And of course each one is entirely different. Yeah.
Right. And yeah, it really can vary. I think the first, when you're thinking about any assessment at the very beginning, the first question is, what do they want to know, right? So what's the actual question? And then, and we can talk a little bit about how I figured that out, because I think that's one of the questions that was asked as well.
Yeah.
But that's going to really formulate kind of what I do next. So oftentimes we do some kind of clinical interview first, and there are times when that is not appropriate, but we usually do some kind of clinical interview that gives us some information from the client or patient themselves. We're also gathering other data, records, collateral information from their treatment team or from family. So gathering that data, and then that gives us some idea of kind of what they can tolerate. And then we choose particular tests and give those tests or administer those tests based off of some of the information that we're collecting, things that we're noticing, what the question is. So as far as that process goes, interview, test, write the report, we'll interpret the data, write the report, provide feedback, which I think a lot of people forget about that last part, and feedback is, I would say, the most important.
And when you say feedback, can you clarify what you mean by that? Like who the feedback is intended for,
right?
And how that works.
So giving feedback, I always try to give feedback to both the team or the referral source, as well as the client themselves.
Do you do that at the same time, or does that depend?
I do it at different times. In the inpatient setting, we're usually doing a feedback session for the treatment team. And the way that we discuss things with the treatment team is just going to be very different than sometimes, most of the time, different than how we would discuss it with the patient. And then, I do individually feedback with the patient. Sometimes people have asked, can we just bring the patient in and us as a team and you come and do feedback? But we're coming in not as part of the treatment team, but as a consult, kind of an outside. And so we don't want to confuse the client, suggesting that we're
You're another kind of treatment provider.
Exactly.
That you're kind of there. I was going to say on their side. It's not that you're not on their side.
Right.
I mean, it's in that way similar to any kind of assessment or evaluation position, right? That you're answering a question,
Right.
not in this case, not for the court, but for the team.
Yes.
And it's important for you that the patient understands that and that you're not kind of joining their treatment.
Exactly. So that the roles are very clear.
Got it.
Mm-hmm.
Okay, what are some of the more common referral questions then that you get in the hospital?
Yeah, so I think the two most common referral questions we get is cognitive functioning. So how is this person thinking? What's their IQ?
Right.
This person seems to have some memory issues, that kind of cognitive realm.
So trying to clarify what's going on there.
Mm-hmm.
Yeah.
And then the other common one is personality or emotional functioning. Oftentimes the referral is, they say something like diagnostic clarification. So they may be wondering about different diagnoses and which one's the most appropriate.
Mm-hmm.
And looking at major mental illness versus personality disorders.
Or both present.
Exactly.
Okay. Are there ever reasons for you to refuse an assessment?
Yes.
Could you expand upon those?
Yeah. So
how about what would be some reasons for you to turn down an assessment request?
So a few different things. One, I think, is the one you mentioned. If someone's acutely psychotic or having pretty active symptoms and the team does not feel like what we call at their baseline, so at kind of their best functioning or where we think their functioning is going to be, I will postpone or discontinue testing or not even start testing, because we're not going to give you very much information except how they're functioning when they're acutely psychotic.
You're essentially going to be saying almost what they're saying when they refer the person.
Right.
Like, it's hard for us to tell.
Exactly.
Right? And so that's not very useful for, you're not able to get really valid information then.
Exactly. So that's probably the number one, and a question I always ask when I'm consulting with the team when we get a testing case. Another one is if the patient refuses, or we realize that the patient is not putting forth effort, and there could be multiple reasons for that. It could be anxiety, it could be feigning or malingering, it could be a lot of different reasons. So we may discontinue testing for that reason. Another one is if they decide they want to go through medication changes. So if we're testing someone and they start changing their medicines, then what are we measuring? Are we measuring what someone looks like? They may become more psychotic, and so it's just going to invalidate those results.
Or maybe like an acute medical illness.
Right.
I imagine that could be another
absolutely
reason. So actually a whole host of reasons. You really have to take that case by case. There was a safety question before about just general safety in the hospital. With assessment, what are some of the precautions that you take for safety, or safety measures you take to ensure that you feel comfortable or your students you're supervising are comfortable and safe? What's the typical setup?
Well, we are always consulting with the team to ask about any kind of behavioral concerns or patterns, just so that we can be aware. We look at the chart to see how that person's doing in general and most recently. On the day of testing, so if we're going to go do a test with someone, we're checking in with nursing staff to see how they're doing that day. We're checking the records just to see how the last couple of days have been, because we don't want to test someone when they're in a lot of distress either. That's going to impact the results, or at least kind of like distress that's not normal for them. And then if all that's fine, we go and check in with the patient themselves, see how they're doing as well. Sometimes people have bad days and they don't, and that can impact testing. So we got to do all these things. Then we get into a room with them, and we always we have safety precautions. So sitting next to the door, we have phones that if you knock off the hook can sound alarms if something happens. We always carry a radio. So there's a lot of different safety measures that we take into consideration. And ultimately, I go by this, and I always tell everyone that I'm supervising that I don't care if it ruins a test. If there's some reason that you feel unsafe, things are escalating in that room, you just discontinue, you
Right.
leave, you stop whatever it is.
You prioritize safety over the validity of that information.
Exactly.
Because also, what does it matter if you're not able to then use it because
Exactly.
you're hurt? Or,
Yes.
Yeah.
And there's always we have so many tests, luckily.
Right. You can replace them.
Yes, we can do something
Lots.
else.
That's the, kind of another piece of assessment that we'll talk about in class, right? Is that if we're looking at, say, like a specific measure for diagnosing PTSD, there's multiple tools. So
Exactly.
if you started with one and then you had to stop, and then you don't want to continue with that one,
Yeah.
you could just select something else.
Yes.
And that's nearly always an option.
Yes.
Right? So you talked a little bit about the process, but what is the typical number of sessions and length of sessions? I know that varies very dramatically by
Right.
the individual and what they can tolerate.
Yes.
Like, what's the general
If I had to
protocol?
give a number, what would it be? So I'll give an example. When I was doing neuropsychological evaluations out in the community as a doctoral student, I could meet with one person for 8 hours, right? So that would be, and we would give it's neuropsych assessment, so it's much more complex. I won't get into the details of that, but we would give something like 10 different tests.
Right.
So a pretty lengthy assessment.
You'd have little breaks here and there, but it's all day essentially. And then you would only need that one day, right?
Exactly,
Most
and you'd
of the
be
time.
done.
Yeah.
The population that I work with are much more complex. Oftentimes, their ability to tolerate doing tests varies. Some people can only tolerate a half hour at a time, some an hour, some can go 2-3 hours, but those are the exceptions, not the rules.
Mm-hmm.
And so we take that into consideration when we're developing what tests we're going to use and how long we're going to meet with them.
Mm-hmm.
So, I mean, it's not uncommon that we meet with someone 4 to 6 times to get the testing. And as far as how many tests we could do, I would say on average 4.
Mm-hmm. Okay, perfect. Briefly, as if you can, I know it's hard, but how do you make decisions about which tests to select? So you said one factor is just what people can tolerate, right?
Mm-hmm.
So maybe if you're looking at some kind of intellectual ability or skill, maybe you might do subtests from the waist instead of the whole waist if you're just trying to answer a specific question, like to cut down on time and because of what they can tolerate. But that aside, like, what are some other factors that come into play when you decide what tool is most appropriate?
Right. So the referral question. So we talked about, are they concerned about overall cognitive functioning, which it has a select number of tests? Are they specifically concerned about memory, which is a whole nother set of tests? Are they concerned about executive functioning, which is a whole nother set of tests, right? So narrowing that down. Are they more interested in personality functioning or emotional functioning? Are they worried about trauma? So all of these have subsets of tests. And so by narrowing down what they're asking for, I will be narrowing down what tests to choose.
What you can even pull from.
Yes. The other big thing that I keep in mind is culture. And so understanding, is this an individual that has immigrated from another country? Do they speak English, or is English a second language? And are
they educated here or somewhere else?
Exactly.
Even if English is a comfortable language, right? There are some tests where if you didn't grow up here or you weren't educated here, there's going to be a bias against your performance.
Exactly, and so that's going to help me narrow down to make sure that I'm not pathologizing culture. So that will help me select as well.
And probably like reading level and all of those things.
Yep.
So a whole host of factors. Awesome. But it sounds like another thing you're saying is that it's really essential that you identify the referral question, right?
Yes.
Because if it's just like, hey, assess this person for us, I mean, that gives you no direction, and you could just keep throwing tests at them, right? And you could, and what are you even answering?
Right. And
so
I think
it's really important to know as specifically as possible.
And sometimes I will get a referral, and basically it's what's going on with this person. and so it's important for us to use our own clinical skills as psychologists to go meet with them and say, okay, what is it that you're seeing that you're concerned about? And then helping them nail down exactly what it is they're asking us to assess. Because sometimes they don't even know. And that's understandable. They don't have the training that we do. They don't know exactly what our test measures, what we can or can't measure.
Sometimes your referral sources might not know how to phrase the question, and you kind of help them clarify that.
Exactly.
One of the other questions I got from students, and we will cover this a little bit this week when we go through different assessment tools. We're going to talk a bit about biological assessment and medical advancements in scans, CT, MRI, PET scans. And so I know you're not using those at the hospital, but do you, what is your understanding of biological assessment tools, and are they ever incorporated in any way for you, or are you requesting them from other sources? How does that factor in?
Absolutely. I mean, I take as much data as I possibly can, right? Because I'm really trying to figure out what's going on. And so it would be silly of me not to take that into consideration. It's also sometimes something we recommend. But if someone has a CT scan or an MRI scan, that's gold, especially if for both a personality question, an emotional question, or a cognitive question. We had a case where this individual, they were asking about cognitive functioning, and just so happened that they had a CT scan and had some ischemic changes, and they had on the CT they had suggested a possible diagnosis. And I'm not a medical professional. I don't know every medical diagnosis there is out there. So myself and my intern go and do some research and figure out, okay, what are other symptoms of this besides a brain abnormality, and come to find out some of the memory issues and cognitive issues that we were seeing in this was consistent.
Could be explained by that.
Yeah, and so then we could say, okay, now this is a neurocognitive disorder due to this, this brain
more specificity.
Picture. And this is the beauty of psychology is, okay, this is the brain picture, but here's how it's going to look when you're working with this person, and here's what you can do to help.
One thing those scans cannot do for us, right? They're incredible, and I imagine technology is going to continue to evolve, and we're going to get better and better at this. But right now, we can say, right, okay, there's this issue here, or there's this tumor, or there's been a stroke, or any of that, but we can't say exactly what that's going to look like for the person in front of us, or how it may or may not progress.
Right, and on the flip side, I've had cases where they're asking if there was a cognitive decline. More so, is there a major neurocognitive disorder? And we will see a decline, but we don't have a really solid medical workup. And before we, one of the big things we have to rule out is there a medical reason for this? And so we will often make recommendations of some kind of, it'd be beneficial to get a CT scan of a brain or an MRI of their brain to see if there are any changes or other things. Yeah.
Awesome. So that's not something you are doing, but it's an important part of what you might recommend.
Absolutely.
There was another more specific question from a student about metabolic cheek swabs, which I'm not very familiar with.
Yeah.
My limited understanding is that they can be used to understand what kind of metabolizer someone is, and make more personalized recommendations about medication. Do you have any experience with that, or do you know if the hospital, this struck me as something that might be more in the realm of the psychiatrist, right? Because they have to make decisions about medication.
Right.
But
I haven't run into that specific test. When I read that, that's what it sounded like. I would probably consult with a psychiatrist, or the psychiatrist would be giving me that kind of information. Though medications in and of themselves can impact people's results on testing. Many of these medications have sedating effects, and so that can impact.
And even non-psychotropic medications, right? So
Yeah.
medications people are taking for something else, for diabetes,
Yep.
you know, it has the potential to produce some of the symptoms that we see.
Absolutely. So understanding the medications is important, and so I'd be consulting with the prescriber on that.
Awesome. Okay, I'm going to stop us here. We're going to go to a part 2.